everybody. Good afternoon. Welcome to our medication-assisted treatment echo for today. So great to have you all joining us. We'll start off with introductions as we usually do. So Troy Jorgensen, Program Manager for Project Echo.
Hi, I'm Kim Nishik. I'm Physician Assistant at Northern Nevada Hopes Medication-Assisted Treatment Program.
I'm Echo Troop. I'm a licensed clinical social worker with the MAP program at Northern Nevada Hopes.
I'm Shalene. I'm a pharmacist at Northern Nevada Hopes.
I'm Kristen Davis-Quayla. I'm the Chief Behavioral Health Officer at Hopes.
And my name is Danica Pierce. I'm a licensed clinical social worker, and I'm the MAP program coordinator at Northern Nevada Hopes. And so thank you for joining us today. It's exciting to have you all here.
So the next step is for us to open it up to see if anyone has any specific patient cases that they want to consult with the team about, or any questions about your MAT programs or prescribing. So if there's anything out there, please feel free to unmute yourself with the microphone icon in the lower left corner of the Zoom window, or *6 if you're joined by telephone. So
I have a question.
Yeah, Holly, please go ahead.
Hi. So we're bringing Sublocade into our picture maybe in the future, and wondering, we have a few patients right off the bat, the docs are talking about starting on Sublocade related to, potential they could be diverting, or the patient feels like it'll help them to participate in a better manner. I'm wondering what limitations are and why I haven't heard a whole lot about that yet.
I think for us, the limitation is cost. Am I correct?
Okay.
Yes.
Yeah, that's not a product that we're using currently. I know that Dr. Broadhead is clearly missing today, our entertainment. So, and he, he's going to have the best information for you about that. So if you're present next time, maybe we can bring this up again. I know that he has some opinions about that product that I'm sure he would love to share with you. So we're not currently using it. I think there are certainly some benefits to the medication, and there are also some drawbacks.
I'll hit him up next week.
All right.
He's back.
Good.
I'm pretty sure he said he's.
Yeah, he does. He doesn't use it. I should say that.
Okay.
It's not
Okay. I'll be interested to hear why. Thank you.
Yeah, I will say I know that one concern is that if, certainly cost, but also if with that product, there's less of an incentive for them to engage in behavioral health services.
Right.
So I know that that's, sometimes a concern. It's just finding the right, different medications are going to be more beneficial for different patients and different populations. And so there's certainly some folks that could, where the benefits kind of outweigh the cost or whatever. But I know that that's kind of one of the primary concerns, at least in our world, in a fully fledged MAP program.
Perfect. Thank you.
Dr. Andraki, looks like you just joined us. Could you introduce yourself, please?
Hi, my name is Stephen Andraki. I'm in Pahrump, and I'm a MD, family medicine and addiction medicine, and I run the MAT program for the whole county of Nye, I believe.
Great. Thanks, Dr. Andraki. And then Sarah Draves also joined us. Could you introduce yourself, please?
Hi, yeah, sure. I'm Sarah Draves. I'm in Spring Creek, Nevada. I'm working on my master's through UNR right now with a focus on family. So I'll be doing family nurse practitioner here shortly.
Great. Thanks, Sarah. Good to have you. So we'll keep it open here. Any other questions, patients, that sort of thing that we can review with you?
I think that's a no.
Okay.
Yeah.
Gotta wait out that awkward silence to see if anybody pipes up.
Just long enough.
All right, we'll get going here then with the talk. but it's always open for questions or comments, so feel free to unmute yourselves, again, with that little microphone icon. *6 if you're joined by phone, and there's also that chat box, so I'll send something out through the chat so you can all see that. So feel free to write in your questions or comments through that as well. So we'll go ahead.
Okay, so today we're talking about working with MAP patients, and this is the rules of engagement. So kind of the do's and do nots in the clinic and with the patients. Okay, so 10 rules of engagement. So first of all, do a self-assessment of your attitudes. Create a culture of compassion. Be realistic. Know your role and your limits. Own your feelings. Watch your mouth. Do not get into power struggles. Learn motivational enhancement techniques. If you don't know, then ask. And lastly, practice self-care. Okay, so first of all, do a self-assessment of attitudes. So before you even start, I guess, a MAP program or seeing some of these patients, it's important to know what your attitudes and beliefs are, what your values about addiction or drug use in general. It's kind of good to know where you stand before you start treating or counseling patients with these issues. So do you know or love someone who struggles with addiction? You know, how has this impacted you? What is their story? Is that what has brought you to what you're doing today? What's your own substance use or abuse history? And how does this shape your attitudes or your actions or how you treat patients in general? Like, for example, like, I got clean on my own. Why can't this person do it? And so that would be an example of being pretty rigid or strict about it. Whereas on the other hand, if you think, oh, I know how hard this is, this person needs more leniency, that would be more on the enabling end, allowing them, you know, too much freedom or boundaries or stretching the rules for that. So if you have any unresolved issues around any of the above, seek help before you go into treating others who may have the same problems. Number 2, create a culture of compassion. So most importantly, start where the patient is. Find out where they are and if they actually want to change or if they have goals or expectations. And part of it is having realistic expectations about what the patient might want. Next would be trust, but also verify. I think this goes more along with giving the patients the benefit of the doubt. I'm sure we've all had our share of crazy patient stories. And there may be a little truth sprinkled in with that every once in a while if it seems a little crazy. I feel pretty lucky to work with a great team who knows a lot of the patients well, both therapists and medical assistants. And so we are able to kind of bounce things off each other and help keep each other in check. I know everyone doesn't have that, but it certainly helps with the story corroboration when things seem a little off. Next, don't gossip or speak ill of patients and other staff. That just kind of goes along with working with people or medicine in general. Model person-centered language with the staff. I think this kind of goes along with watching your mouth as well. Like, for example, if you're talking about someone who struggles with alcohol dependence, that would be the way you want to talk about it, as opposed to calling someone an alcoholic or calling someone a drug addict. Keeping your own motivations in check. Again, just good rules in general to think first, give it a second, and then start talking. And then also taking time for self-care. Compassion for yourself creates more space and compassion for others. So taking care of yourself, meaning you'll probably take care of other people better as well. All right, next is being realistic. It's important to know addiction is chronic relapsing disease. This is not going to be a perfect path for anybody. So knowing that relapse is part of the recovery process, and being able to kind of keep that tucked in the back of your brain. So if we become punitive, or if we try to punish the patient when they're having a relapse or they're struggling, they're less likely to trust you, engage with you, want to continue care with you. It's also good to know that patients in active addiction lie, cheat, and steal and manipulate. And this would be to get their needs met. Manipulation has worked for them. It's how things have worked for them for likely quite some time. And it may or may not be a survival skill. So that will likely continue to come up. We can't expect them to suddenly stop being manipulative unless we kind of train them otherwise, give them some skills to help when they, bump up against their obstacles.
And really quick, just to tie it back to the first one about really kind of assessing our own attitudes and values around addiction. Our ability to be realistic in our expectations is going to be directly related to that. It's to really recognizing and knowing how we feel, what our thoughts and feelings are about addiction. Because if we're having sort of our own emotional response to these kinds of behaviors, we're going to be less likely to be able to handle these behaviors in a way that is, conducive for them to stay engaged. That's always going to tie back to that.
Thank you. Okay. Next is knowing your role and your limits. So knowing that you cannot treat this disease alone. Recovery takes a team and is multifaceted. Again, we're really lucky at Hopes to have a great group to work with. I feel really fortunate as a provider to be able to pull in one of the therapists when I need them, which I do often, and I know I'm spoiled. But, if any type of kind of external support is helpful. We also have case management, which is helpful as well in terms of meeting their other needs. Because if they have housing or financial issues, then their chance of maintaining recovery is less. It's good to know that you are not responsible for a patient's relapse. Again, part of the disease process. It's kind of like if you have a patient with diabetes and they start slipping up and their numbers get crazy, their blood sugar gets crazy. That's not your fault, and same goes for treating MAT patients.
Which is important too, because sometimes they're going to try to blame it on you when you make decisions that they don't like.
Yes.
You get a lot of, if you do this, then I'm going to relapse kind of things. So it's really important to keep this in mind, because sometimes it's easy for us to take that on and to kind of internalize that, especially when we've invested a lot of time and energy and caring into somebody.
I say, going back to the lying and cheating and stealing and manipulating to get your needs met, it's easy when you've been working really hard with somebody and kind of getting invested in their progress, and then you find out they've been lying to you, manipulating you, to take that personally. And it's important to remember that that is a symptom of the illness. Those behaviors truly are a symptom, just like we wouldn't take it personally. A person with Parkinson's comes into our office and their tremors knock something off our desk. We wouldn't take that personally, nor as an affront to our relationship with them. And similarly, lying and cheating and stealing and manipulating are symptoms as part of the disease process.
Thanks. So also not working harder than the patient. So try not to be their rescuer. You can't take on all their problems. You are not going to fix them. And if you just keep taking and taking and trying to rescue, you will drown. And that would be part of the self-care as well. And then going along too, in terms of not being responsible for the patient's issues, is maintaining boundaries. So there's a high level of burnout in providers that work with patients with addiction, and it's due to unhealthy boundaries, getting too invested, taking on too much. So it's good to have the healthy balance between having some type of structure without letting the patient walk all over you.
You guys are in a lot of situations where in collaborative practice where the provider or where the provider is too rigid or the counselor is too enabling or opposite. What do you do in those situations?
You have good, healthy relationships with your team members and you work it out.
Consult.
In a perfect world. Yeah, that's the goal. But yeah, that does happen. But also that's sort of the benefit of working in a team is because, you know, you kind of need that. You need those different perspectives to be able to find the balance to provide the best care. So sometimes it's uncomfortable to have those conversations, but it's also incredibly valuable.
And the challenge for solo practitioners, right, often out in the rural settings is you don't have that team necessarily, and so you have to make sure you have a colleague, even if they aren't providing that, a colleague whose perspective you really trust, that you can go and say, I'm having this reaction to this person, what are you thinking? And somebody you can bounce that off of.
And it's really easy when you're working with this clientele and it's fast paced and you have a lot of stressors to slip into these boundaries that are either too lenient or too rigid without even acknowledging it until you're so far along that it's becoming problematic for you.
I mean, I've certainly stepped out of the room a few times knowing that I don't have anyone else around to help me, just to kind of pull back and give myself a breather and think about what's going on before I start making unilateral decisions. So it's also important to be aware, check in with your own internal experiences when you're interacting with the patients. So kind of just knowing where you are personally, and are you in a good place? Are you doing a good job treating patients? Or, you know, do you have a lot going on in your life? You're stressed, your fuse is short, and how is this impacting your patient care? This is the triangle. Okay, so these are the roles that we might play as a provider, or I don't know, maybe as a therapist too. I don't know about that. Yeah. So we've talked a little bit about this before. So in terms of being more of a punisher, so that would be having strict boundaries, being more rigid, and at some points in time you might find yourself trending towards that personality or that style. And then moving down to the enabler, so that would be where your boundaries are maybe more fluid, where you've known the patient for a while, you're invested in their story, you feel like they're struggling, you feel sorry for them, and so you make exceptions for them that maybe you would not for other patients. And then going down the end of the rescuer, that would be, again, where you might get in over your head. You're trying to save the person, you're going out of your way to save them, but maybe the patient is not willing to put in the effort. And so at some point you might bounce between all three of those roles, but ideally you should be more in the middle and have good boundaries with your treatment or with therapy. Do you have anything to add?
Yeah, well, you probably have more too, but one thing I would add that's important to consider is that this can look different with different patients. So again, kind of going back to the importance of your own self-assessment and identifying your own addiction history, or you know, family members or people you care about who struggle with addiction, because of countertransference, which, you know, we can talk about more if we want to, but being able to identify that with perhaps a certain type of client, you tend to be more enabling. Maybe your little brother struggles with addiction, and so when you're working with young men, you sort of fall more into that enabler because of your relationship with your brother, just for example. Or the opposite, you know, maybe you grew up in a family where your father was an alcoholic and was abusive, and so somebody who's an older gentleman, you might be more of a punisher. So it's important to just recognize with client to client what's coming up for you internally, and which of these, because we all do this. This is like a very normal pattern. It's not right or wrong or good or bad. It's just something to be aware of. And so being able to identify in the moment and with each individual patient and client, like, where am I in the triangle, and how do I, what do I need to do to kind of pull myself back centered? Yeah. Anything else?
No, yeah, you said that really well. And I think even in particular, even if it isn't related to a personal experience, if you have a particular value around somebody, like somebody with kids, right? The stay-at-home parent who's raising children while they're using, if that's a particular button for you, you'll find yourself drifting probably to like the scolding, punishing, or there's cultural, kind of our cultural beliefs can affect this as well.
Do you have anything else, Echo? No?
Number 5, own your feelings. So our feelings are our own, and you have to own them. So basically just, again, knowing where you are. And this is kind of what we've been talking about. The patient's behaviors don't make us angry. That's more about keeping yourself in check. Again, I'm sure at some point someone will touch your nerve, you know, make you upset. And I guess you feel like the patient does make you angry, but it's probably more of something that you have going on with yourself that you're allowing them to kind of break down that wall. And for example, if you find yourself becoming emotionally flooded during an interaction with a patient, kind of need to keep yourself in check, be a signal that you need to stop and kind of think about what's happening. Or if you just feel overwhelmed. Again, like I said before, every once in a while, I'll just tell the patient that I'll be right back, and I'll leave the room, and I'll just go back and take a breather, think about what's actually going on, and, you know, kind of come back into the room refreshed. Maybe I have a plan, maybe I don't have a plan, but at least I've kind of de-escalated myself a little bit. And it's important to know that you can only be manipulated if you allow it. So have good boundaries, listen to your gut. If you have a feeling that something's not right, it's probably because it's not. Even if you really like the patient, you really want them to succeed. Number 6, watch your mouth. So use person-first language. We talked about this a little bit before. Using the term a patient who struggles with addiction rather than calling them an addict. Avoiding stigmatizing terms such as junkie, addict, abuser, or drug seeker. Try to avoid the use of dirty, as in they had a positive urine drug screen. When you talk to them or other, you know, providers or staff, avoid use of talking about getting clean. And also using the word habit. So using the word habit means that there's a lack of willpower, like the patient could get better, but they just don't want to, or they don't want to put in the effort. It's also important to avoid use of shame, guilt, or fear mongering to try to convince the patient to come to where you are or come to your point in treatment. For example, you know, again, someone with children, don't you love your children enough to get clean for them? Or if you don't stop using, you'll be dead within 6 months. Both are not great things to say to someone. Anything else?
Yeah, I mean, I've had so many different clients tell me these kinds of things, being told these kinds of things, like my doctor told me I'm a bad mom, things like that, that is so incredibly unhelpful for the situation. Just, just further shames them and drives them deeper into addiction. And so just being mindful of the things that you're saying and the way that you're saying them. We discussed this a little bit in our last clinic, this topic of, Dr. Broadhead had brought up, where's the line between giving somebody honest feedback about the risks of using versus how do you kind of balance that? And I think my response at that time was really about the relationship. If you're developing positive rapport with these patients, and you feel like that relationship is at a place where you can say something like your health is at risk, those kinds of things, that's sort of different than, one-stop shop. My primary care doctor told me I'm a bad mom, or that I'm going to be dead in 6 months, is different. And so just being mindful of one of the benefits of doing that is that you are getting to see these patients very frequently. And so theoretically, right, we're building these really hopefully wonderful relationships with these folks. And so but just being mindful of how powerful our words can be, and that shame is really almost always the driving force behind addiction anyway. And so using shaming language is just adding fuel to the fire.
Number 7, do not engage in power struggles. So basically, yelling at the patient, aggressive confrontation will make them more defensive. Their chance of change based on that is not good. This kind of goes back to even shaming, same idea. It's important to know that ambivalence about substance use and their desire to change is normal. It is a really important obstacle in recovery. So knowing how motivated they are, and again, meeting the patient where they are, will kind of help with this. And then, having good boundaries. Again, with these MAT patients, you get to know them pretty well. And so as you develop your relationship over time, hopefully kind of the alliance that you have with them should be used in the future to kind of help move the patient in a positive direction, and will help their long-term recovery. And also having empathy, being supportive and directive, and having boundaries will help provide conditions where change can occur in a positive direction for the patient. So next, learning motivational enhancement techniques. Taking a motivational interviewing training. I did one of these a couple of months ago. It was pretty fantastic. It was really hard work. It was exhausting because I'm not a therapist. But it's a really good technique to learn how to talk to patients, figure out where they are, and kind of coming to where they are without judging them. It's really effective in terms of sometimes just repeating back what they said to you, maybe asking it in a question form. It helps when you can listen and kind of reflect back what they're saying to you, and helping them understand maybe where their discrepancy between what their actions are and what their goals are, or what they're trying to accomplish. Like for example, if someone wants to slow down on drinking alcohol and it's causing problems in the home, it's causing problems with their spouse. However, they're going out every single night, they stay out late, they drink, they get hungover the next day. And they think that's an important part of, I don't know, maybe their social life. Trying to talk to them about, you know, how that might be causing problems at home or with their spouse and what they're doing every day. So avoiding arguments, kind of adjusting to their resistance to change instead of telling them that they're wrong or pointing out what they could do better. And just help the patient feel optimistic about where they're going. Anything else, touchy-feely therapist, about this? This is more your realm.
I think kind of the key here is really, I mean, we all of us have change processes that we're going through all the time, or just as human beings. And so none of us who are present here and nobody else that you're going to ask anywhere is going to say, I love being told what to do, and I love being told that I'm wrong, and I love being told that this isn't working in my life and I should fix it. That's just not how human beings operate. We don't like that. And so helping people, we don't like being told these things, but we also know internally when they exist. And so being able to help people just identify that for themselves and to kind of find those discrepancies around, I'm saying one thing and I want this thing, but I'm doing this thing that's sort of getting in the way. And so helping people identify that on their own is far more sustainable in terms of change than anybody else trying to force that upon them. And so it's really about motivational interviewing or motivational enhancement techniques are really designed to help you do that. And I tell people all the time, like, everybody should take this because you can use it at home with your spouse. You can use it with your kids. It's very effective. It's sort of like Jedi mind tricks. And so we have a video. Do we want to do that?
Yeah, we'll do the video. I just want to pause real quick and see if anybody has any questions or comments they want to share right now.
I have a question. Can you hear me?
Yep, go ahead.
All right. Looking at that triangle of the punisher and the enabler, I guess I'm kind of identifying more towards the enabler side because, you know, I feel like I've been taught, you know, if someone comes in and they have positive urine drug screen, you know, you're not going to fire them from your practice. You're going to try to work with them. Or if a patient misses their appointment, you know, you're still going to try to work with them to get back in. And I guess it's hard to know where to draw that line. You know, like if a patient misses their appointment, I probably would still send a prescription for them until I can see them for their next appointment. But then that can kind of spiral. So I guess, how do you know where to draw that line?
Isn't that the question?
Oh, it's tough. I mean, patients miss their appointments all the time, you know, and then we have a mat phone. Then we get a text, ooh, I just forgot. I thought my appointment was today. I think I saw this text right before I came here. And so frequently what we'll do is, if I'm going to write them a prescription, but I don't have time to see them, we'll still have them come in, leave a urine sample, and then write a prescription after that, but they still have to make an appointment with me within a short amount of time.
Well, and really it depends on the pattern. It's the particular client or patient. So if you have somebody that's going along and doing well and, you know, doesn't normally miss appointments, and then they miss or they forget or something happens, you know, that's different information than somebody who is consistently not showing up and maybe testing positive and those kinds of things. So really, it's kind of a case-by-case thing that you just, you know, you got to use your gut and you got to ask questions and get as much information as you can. And if somebody is consistently having these kinds of issues, then we need to look at their treatment plan. That's usually an indication that they don't have enough treatment, they're not getting enough support one way or another. And so it think it's a really good question, because I think probably a lot of us here and a lot of us who do medication-assisted treatment are going to kind of tend to be in that enabler corner. I think just because of the kind of work that it is. But it's a hard question. It's a challenging one. And so, like Kristen was saying, to the best of, what you have access to, making sure that you're staffing cases and bouncing these things off of colleagues and things, getting feedback. And again, always checking in with your own stuff and trying to identify in the moment with this, with each situation, is what's coming up for me about this patient and this situation, or is it about something else? Is always really important and can be helpful to make those kinds of decisions. So,
Thank you. I appreciate it.
And I give all the solo providers out there a lot of credit for taking this on, because it is not easy. And if you have mostly yourself to make all the decisions, it's not, probably a lot of self-questioning.
Yeah. And also use this as a resource. When things come up in between clinics that are like that, where you're like, I'm not sure, write it down and bring it up here when we open our clinics, and we can talk through it. That's what we're here for.
Anything else out there before we move on to that video?
So let me just set up the video. It's a pretty short video, but it's kind of just an example of what a motivational interviewing conversation looks like, just so you can kind of get a flavor if you're not familiar. And if you are familiar, it's just kind of a good reminder, reinforcer. So hopefully it's helpful.
My name is Karen. I'm a nurse this afternoon.
Nice to meet you.
Nice to meet you. So, how are you feeling?
Oh, okay. Burns a little bit, but I'm just waiting for the doctor to check my stitches, then I'm going home.
Well, that's great. It's a good thing that you're going home soon.
Mm-hmm.
I have 10 minutes that I can maybe sit down and talk with you. If you have any concerns or questions for me, is there anything that you'd like to talk to me about?
Not really, but honestly, this has been really bugging me. This priest came in here and gave me this flyer for AA, and I'm kind of offended. Like, why would he give this to me? I don't know. So, it just bothers me.
So you're saying that a priest came by and gave you this brochure for Alcoholic Anonymous.
Yeah.
Am I right?
Yeah.
And this is really upsetting you because you don't think that you need.
I'm not an alcoholic.
You don't believe that you're an alcoholic.
No.
I mean, I could understand how upset you can be if people think that you're something that you're not, right? Would you like us to explore a bit more about, why do you think that the priest gave you this? Do you have any ideas why he would hand you such, like a brochure like this?
Well, I mean, I guess it kind of makes sense because I'm here because I got into a bar fight, right? And I got hurt. So maybe he just thought, bar fight, she's got to be a drunk. Maybe that's what he thought. I don't know.
Okay, so would you like to tell me a bit more about this bar fight that you...
Honestly, I don't remember much because I know I was drinking, I was having some fun with my friends, but I guess this girl just got to me, and sometimes I get a little crazy, and I don't know what happened, but I know I hurt now.
So you got into a bar fight, right? And you were drunk. You
I was hammered. Oh yeah.
And you didn't know what was really going on, but you just think that maybe this girl was not saying something good to you, and then you got into this fight.
Yeah.
Okay. Would you allow me to explore a little bit more about the drinking and then alcohol? It's just like okay. So how does alcohol affect you? Like, what does it do for you? Is there like?
I like it. It's fun. I go out with my friends and we go drinking, and like after work, it's like the best way to just chill, is to have a beer or just relax. So for me, it's fun, and it's my way of just relaxing and hanging out with my friends.
Yeah, I understand. So you like having fun with your friends. Drinking is a normal thing for you guys to do.
Yeah.
And you don't see a problem with what you're doing with your friends. Like you're just drinking.
I'm 25. I'm not driving. You know, yeah, it's just fun.
So it seems to me that drinking is not really a problem that you in your life right now.
No.
But would you say though that there are some negative effects that alcohol is doing in your life right now? Would you like to tell me if it's affecting you in that way?
Well, I mean, I'm kind of cut up, so that's not a good thing related to my drinking. I guess Joey, he's my boyfriend. He really doesn't like it when I drink, and we get into a lot of fights, and he says I'm just not normal when I drink. So I guess that would be the negative stuff.
So, like you said, your friends drink, you drink, and it's something fun. But on the flip side, on the bad side, it's affecting your relationship with your boyfriend. He does not like it, the way you act when you're drinking.
Yeah.
So it is affecting the relationship negatively. Okay? So back on the Alcoholics Anonymous, if you don't mind. What do you know about AA?
It's a meeting for people who drink. Talk about it.
Okay, so you're on the right track about the people meeting, and it's a group of people that talk about alcohol. Okay, so with your boyfriend, it sounds to me that would you say how important is he in your life?
I'm gonna marry that guy. He's important. We're gonna have a life together.
Okay, so that's great. At least you're thinking about a future with Joey, and you think that he's really important in your life right now. And then you also said that he does not agree with the drinking. I would like to ask you this question. Now, would you be willing to take it a step further and maybe check out one of these programs for the sake of your relationship? Is that something that you're willing to look at?
I'm willing to.
In the future?
Yeah. I've never thought of it before, but I'm willing.
So, okay, I would like to give you a scale of 1 to 10. In a scale of 1 to 10, how likely would you go and check out one of these programs?
Maybe 6 out of 10.
So you would say it's a 6. That's very surprising because it's not a 1. Like it's very good. Why would you say it's not a 1 and it's a 6 that you're likely to go?
Because of Joey. He doesn't like me drinking. I mean, I'm only 25. It's not affecting my health now, but I know when I get older, it could really affect my health. And Joey wants to have babies, and he keeps telling me I can't drink if I want to get pregnant. So, I mean, those are the things.
That's really, I commend you for that. You're thinking about a future with Joey. You're thinking that maybe you'll have children with him someday, and if you do try, you think that it will make your relationship better. It will affect your relationship in a good way. You said it's a 6, right? So what do you think would happen or would need to happen to make it a 9 for you? Like you're really most likely to just go and try one of these programs?
Well, I guess if the place was close and if I liked the people there and if I got something out of it, then it would make me go.
Okay, that sounds good. It sounds reasonable that if it's closer to you, it's easier for you to stop by.
Yeah.
If you'd like, if you're interested, I would be able to help you find a place, a closer area wherein the program is held and it's easier for you to get there. It's closer to your house. Would you be willing to find out a bit more about that?
Sure, yeah.
Okay, so thank you for talking to me about this, about your relationship with Joey and how alcohol is maybe affecting your relationship, and and you're maybe willing to go and try one of these programs. Would you like to meet up with me in the next 2 weeks and see how this program is to you? Like if you've tried it, if you have any more questions or concerns for me, look at where you are at in this situation. Is that something
in 2 weeks? Yeah.
In 2 weeks, yeah. Would you be willing to? Yeah. Okay, so thank you, Leanne. This is a big step for you, I know, and it's hard to make a step like this, but I'm thankful that we have this talk today, and I hope to see you again soon in 2 weeks.
Thank you.
Thank you. Bye.
Okay, so that was a good video. She's very patient and kind. Are
there any
anything else?
questions on that?
only we all had someone like that in our office that we could pull in and do that counseling. That would be amazing. All right, number 9, if you don't know, then ask. So if something comes up, you don't know how to handle it, you feel like the pieces aren't coming together, ask for help. So, I mean, we've been talking about this. Get some kind of a consult another provider, consult a therapist, attend an echo clinic, bring your questions. And then if you're talking to a patient and you don't know what they're talking about, ask them to clarify. If they're talking about things in drug culture that you don't know what it is, they're using slang words about use or anything to do with it, ask them. I found they're pretty open to explaining it to me if I don't know. Also, most importantly, be humble. You know, you're not going to know everything, so just be willing to accept that and ask the proper questions.
One thing too I think is important about like slang, just to give an example, is for example the word dope. So when some people say dope, they're talking about marijuana. Sometimes our older folks, they're referring to marijuana. Sometimes when people say dope, they're talking about methamphetamine, and sometimes they're talking about heroin. And so if they're just saying dope, and you're making an assumption that they're talking about heroin, for example, when really they're talking about something else, it's really important to make sure that you know what it is that they're referring to, so that we're, you know, having correct information and making the right decisions.
And it changes all the time.
And it changes all the time.
You're working with people
Yeah.
constantly in this field, and somebody will come in with some new word, and you're like, what is that now? Right?
I know.
Yeah.
I'm like eternally surprised.
Yeah.
By the new words all the time.
All right.
Did you send that? You did.
Yes, yes. Lastly, most importantly for you, practice self-care. Being kind to yourself, creating more space for kindness and compassion for others. It's important to take time for yourself, take time off work, practice good self-care. It will help you be present, mindful, and more engaged with your patients. It'll also make you feel more refreshed. Because if you have nothing to give, then it's hard to be effective at your job.
You gotta put gas in the gas tank.
Emily, go ahead.
Sorry, I didn't mean to do that. I don't have a question.
All right. So yeah, we've got plenty of time today for questions about the presentation or any other questions that you might have. So yeah, Amanda, go ahead.
So I'm not in a provider role right now. I work in acute care and critical. I kind of was wondering if you had like the people with nurses working come in, like we have patients that come in with a history of drug addiction, and I kind of feel like it is really common to feel like we're getting into a power struggle with them. Especially with if the provider doesn't want to order more than like order what they want, or sometimes if they do order what they want, then I feel like I'm an enabler by giving them what they want, and it becomes kind of exhausting, and I'm not sure what the best thing to do in the acute care setting is.
Yeah, that's a great question, and I can jump in, having worked in acute care settings. So yeah, I've worked in acute care settings, and that is a big challenge. And if the most effective approach is to have, well, we'll do this different levels. The most effective approach is to have system-wide, whatever the healthcare system is, system-wide, like agreements and policies, and a method to how you're going to manage that. If you can't get it at a system level, which is hard, then at least within your team, right, your prescribing team where you're sharing patients. If I don't know if you were kind of cutting in and out at the beginning, so I didn't catch if you were in critical care, it sounded like, or a hospitalist. But
the bedside nurse. So I'm, it's like not my call what to prescribe, but sometimes it is like what to give or not to give. And that becomes like, there's like certain patients that will become really manipulative and will act out if they don't get what they want. So I don't want to necessarily give in.
right.
And it becomes tricky. And
Sure, it sets precedence for that the word gets around sometimes when other patients come in, and yeah.
mm-hmm.
Yeah, so if you have the relationship with the prescriber that that there can be boundaries around that, and with the other staff that's going to be managing that patient on a shift-to-shift basis, so that at least you have a kind of as part of the care plan, you have a here's how we're going to respond to X, Y, and Z, and here's how we're going to manage these particular medications with this person, and then that can be a fluid plan. That it can be, you know, as part of a huddle that morning, like, oh, this came up on the night shift. Oh, okay, let's modify the plan in this way. It is individualized, but again, if you can't have a kind of a system level process, at least within whoever's managing that patient during that time period, then that's really critical, because it's easy for it to become, you know, a manipulation or a shift to shift kind of difference, or this nurse is nice and this one's mean, or, I mean, all of those dynamics come into play. If you have mental health support of any kind in the acute care setting, you can pull in and have them be part of that treatment planning. That can be helpful too.
Okay, thank you.
Great, thanks for the question. Any other questions, comments, thoughts out there?
Hello.
Yeah, Dr. A, go ahead.
It was Amanda. I was listening to Amanda's question. Are you a provider, Amanda?
Hang on. No, I'm a bedside nurse working in critical care. I'm in graduate school right now, but I'm not working in a provider role.
But you may be in the future.
Yes.
Okay. I think that in the concept of this meeting and what we're talking about is that when you have anybody who has issues that may circulate around desire for opioids or for pain medications, that you might engage in some of the activity that you just learned to empathize and find out what's really going on with the person and refer them into treatment, because that's where you can maybe get the best opportunity to identify that there is something else that's going on with them and there is another way to live. This is such a huge topic, and it's not going to be addressed specifically by you, but believe it or not, with your with any words of suggestion or any words of advice for somebody, it can possibly take them into a recovery role that is amazing. And that's what we all have to do, is to identify wherever we're working, wherever we're at, that we should always be willing to say, if you have any concerns about this, that maybe you should seek some help and talk to somebody about it.
Mm-hmm.
Because I don't even know. I don't know if somebody wants pain medication, if it's strictly a pain problem, or if it's another issue that's going on. Do they have a high tolerance because they use it often? Have they used more? Do they really get euphoria? The problem that I've seen in doing this for years is some people, they're not addicts. They just get so much euphoria from these medications that they're always seeking them out, and then they turn into someone who's drug seeking just because of what's going on in their brains. None of this is anybody's fault, and they don't have to be on the street. They can be in any place, and people can become so euphorized to opioids in the hospital that they want to continue them out of the hospital and start to go on to a dangerous road. And so anybody who's asking for help should be able to get help before they end up taking too many.
Thank you.
Great, yeah, thank you very much, Dr. Andraki.
Yeah, I think that's a really good point, Amanda, is just you can use, anybody can use these sort of motivational enhancement techniques in any setting, in any situation. And so if you can kind of familiarize yourself with, you don't necessarily have to go to a full-on training. It's all over the internet. There are lots of resources. But if you can just kind of familiarize yourself with some of the tactics, and just have a conversation with people and try to get more information, and then educate them about other options and treatment, if you think that that's present. It's a good opportunity to use those skills.
Thanks. That's a really frustrating situation too, because I recently had a patient leave AMA because they really wanted to go smoke a cigarette on oxygen. So it gets very frustrating when you see people choose differently, but I think that's good to keep in mind what we talked about today and trying to use those motivational interviewing techniques, and then accepting that I'm not going to be able to change everything for them.
Right. It's a really hard, it's a challenging thing for those of us who are we go into helping professions because we're helpers and we want to help people. And so it is really frustrating when we see people suffering and struggling and we know how to make it better and they don't do it. It's hard not to take that on because that's just kind of how we're built, or we wouldn't be doing the work that we're doing. And so being able to recognize that we can offer, what we have, but ultimately people have the right to make their own choices, and to be able to kind of separate ourselves and our feelings about that from the situation is really challenging. But also it's really important because we have to take care of ourselves at the end of the day, and not getting caught up and kind of sucked into that allows us to offer and provide better services to everybody.
And I'll make a sort of a non-traditional plug here for Al-Anon, which some of you are probably familiar with. It's traditionally for family and friends of loved ones who are struggling with alcohol use or substance use. But I have known a lot of providers who do a lot of work with people with alcohol and substance use disorders also attend those meetings because the same things apply. It's about how do you protect your boundaries, how do you practice compassion, how do you take care of yourself in these relationships. So most communities, no matter how big or small, have at least one Al-Anon group going, and there's a lot of resources on the web as well. So
I'll add one more thing to Amanda. I'm familiar with the ICU environment, and the providers, the doctors have a whole nother issue to work on. Everybody in the ICU is working on their little pieces. If you have the opportunity to talk to a patient and to discuss with them their decision to use a cigarette, feel empowered that you may be the only person, because of the fact that you're attending this program today, and that you have an interest in it and you're taking interest in it, you can develop the skills that can possibly make the difference. Even for smoking, we don't have to talk about even opioids or it's any addiction, that you may have the ability and the power, and the best way to do it is to learn through these things such as the brief interventional therapies, and just by practicing this, and always give yourself the power that if you're so interested to help somebody, that you can actually be the person to end up making the difference.
Thank you.
Well said.
Allie, go ahead.
Hi, I would love some advice. I'm glad I sat around long enough to think about this. So not a lot, but there's a few of our patients that have 5, 6, 7-year-old kids. And I see them at school. Some of them are patients we're still treating. Some are patients that fell off of our radar. I am drawn to socialize with them. I don't know exactly how to navigate those, not socialize on a regular basis, but chat with them outside of classrooms, not related to their medical care. And as far as boundaries go, I don't really know how to navigate that well, to not alienate them and also not horrify them that their healthcare staff is chatting with them in front of the school.
Do you work in the school, Holly?
I don't work in the school, and I've got a kid in the school, so we drop off at the same time. So there's mamas that are dropping off their kids at the same time that are, you know, heavy heroin users. And so I've chatted with them just about, you know, school type things, about kids and teachers and things like that. And it seems to go well, but I wonder if there are rules around that that I don't understand. I don't want to make them feel odd or like they're not normal humans that I would talk with.
Can I interject? This is Amanda Johnson.
Yes.
So I have experience with this because I used to work at an HIV clinic. And so basically, if I am chatting with a patient, then I am indicating their diagnosis. And so I think one of the things that's relevant here is, are you a primary care provider? Like, are you only doing addiction medicine? And then the other thing that I found to be particularly helpful is to have the conversation with the patient while they're seeing me as a patient about how you will interact with them if you see them in public. Like, do you want me to protect your privacy? Do you want me to pretend like I don't know you? You realize that I'm not doing that to hurt your feelings, but I'm doing that to protect your privacy.
Gotcha. Great advice.
Yeah.
Yeah, so I'm not just addiction. I do care coordination for lots of patients and lots of areas, but that's really great advice.
That, I feel like that's less problematic because you're not indicating their diagnosis by having a conversation with them or indicating that you know them. But I do think it's helpful just to have the conversation before you see them in public about how to navigate that. Because it can really be uncomfortable for them.
Okay.
What about you, Dr. Andraki? Is that a situation you ever encounter with your patients?
It's fascinating because it crosses so many different areas. First of all, we're all humans. We're all connected.
Dr. Andraki, just a little trouble hearing you.
Can you hear me any better?
No, we're losing you. It's almost like it's getting quieter.
I don't know what else I can do. I'm on the internet. I should have good bandwidth.
I can
hear him clearly.
Oh, yeah, perfect.
I hear you just fine.
Huh.
Okay.
Something weird's happening on our end then. All right, keep going then.
Amanda, it's great that you stuck around. It's great that you brought a question up because we don't have a right answer for you. I think that the advice that was given for you is if you're identified as somebody and somebody's talking to you, it may be something obvious. But then again, we're all people. We should all talk to one another. And I think the most important thing that needs to be said is that if somebody is in need, that they should always feel comfortable with talking to you. And if you just go a little bit out of your way to be just friendly on a friendly level without talking any business, that may get them back into to the program. I think that everything that we do treating addiction means that we are always going to be willing to see them back and to treat them no matter what's happened, because when people drop out of the program, they're always ashamed, they always feel guilty, and they feel bad even coming back in. I've got to remind them, you don't ever feel bad. We're always happy to see you. And just those little things can not only save their life, but it can save their children's life. So you're in a situation that it's always going to be affecting more than just one person. So you have to use your best judgment, and you would have to be cautious about what you talk about, but certainly extending yourself and being gracious is probably would be useful in just about all situations unless you're clearly identifying yourself as
so Stephen, that really, that does resonate with me, and that was kind of my experience. You know, there was a particular patient, and we definitely didn't talk anything about the subject of that. We talked a lot about kids and the craziness, and then she started approaching me at school. And the last time she did, she sort of cornered me and said, I really want to come back in the clinic. And that wasn't the awesome place to do it, but I did kind of feel like being available and sort of normalizing the relationship made it less weird. And it was just very casual conversation. I just wasn't entirely sure. Boundaries, probably could be an issue for me, but I thought on many levels it was a good thing to be doing in our tiny community there. So thanks, Stephen.
You answered it yourself. And that's what we need to do. We can't always be following rules, and sometimes we do the wrong thing. I mean, that's just not, we're never expected to always be doing the right thing and making the right judgment, but it's for the right purpose, and we're doing something because we're being human and interacting human, then that's probably going to speak more than making a wrong judgment at some point.
Great, thank you.
Does anyone else have any other questions or thoughts before we wrap up for today? All right, well, thanks so much, everyone. Thanks for the healthy discussion and interaction today. We'll be back in a couple of weeks. It's actually going to be Dr. Kanyar speaking on MAT and pregnancy, and there's a new toolkit out that he'll be reviewing with us. So we'll be here for that one on September 25th is the date for that one. And then after that, October 9th is going to be a presentation on ethics. So ethics for treating alcohol and other addictions. So we'll hope to see this whole group back for those next two sessions, and then on after that. So have a good rest of your day, everyone. Thank you.
Thank you.
Thanks.
Thanks so much.